Well, good evening, everyone. Welcome back again to our Exam Pro webinars for the 2021 ABOG Oral Board examinations. Since it's Sunday, and this is the first Sunday in September, I think we'll be doing our case list defense session. We will get right to our candidates and our case lists. Thank you all who have signed in. I think we have almost 20 of our candidates here with us this evening. I think everybody looks like they're fine on audio, so I'm going to cruise through this very quick. I think everybody knows to just click the raise your hand button. And I can get to you right away, and we'll talk about case lists, and we'll continue through just answering questions through the session also, as anyone would like to. And we have case lists up and ready. Pardis has raised her hand, and also Ashley, thank you, and Maria, thank you. We'll go to Pardis first because she had her hand raised, I believe. Get to Dr. Hosenzada. Pardis trying to, there we go. I think I had you unmuted there. There you go, hi. Can you hear us okay this evening? Hey. Anything particular you'd like to talk about? Let's see. Do we have your case list up? We don't.
I just sent it this afternoon to Beth.
Oh, got it. Okay, it'll get there. We're coming up on one of the holidays also in the next couple of days or so. It may take them a couple of days to get up there, but if you have your case with you, or if you'd like to talk about anything, I will be happy to take on anything that is of interest to you.
Let me just get it open.
Sure, you bet.
I do have quite a bit of infertility patients. Case lists that we can talk about, like primary and secondary amenorrhea would be good ones to go through.
Sounds good. Do you have a particular case that you'd just like to spend maybe 30 seconds presenting, and we'll work on that?
Sure.
Go for it.
Open it. Okay.
Good.
All right. So I have this only because I've been told that primary amenorrhea can be challenging, and I have this case on my.
Okay, sure. Let's do it.
Amenorrhea first.
Sure, go ahead. What do you have in your case there?
Sorry, I am having a hard time finding that. Just give me, okay.
Okay, dude, take your time. We've got a whole hour. We're good. We're good.
Okay, so I have a 16-year-old G0 who presented with primary amenorrhea with absence of secondary sexual characteristics. Do you want me to go through the rest of her diagnostic?
Sure, yeah, go ahead. Yeah, go ahead.
Amenorrhea workup showed elevated FSH level with low E2 and progesterone. Abdominal ultrasound was unsatisfactory. Therefore, we ordered the pelvic MRI, which showed a small uterus with bilateral ovaries. And the diagnosis ended up being a premature ovarian insufficiency prior to puberty. We started on HRTs.
Got it. Let's start there. So they would take this from the beginning. I think 16-year-old comes in because she has not had a menstrual period ever in her life, and her parents are concerned, and so is she. What would be your basic differential diagnosis, just starting off without having any of the other information aside from just primary amenorrhea at age 16?
So thinking about primary amenorrhea, things that come to my mind are initially or are characterized into different categories. So initially structural causes. So would it be an obstruction due to an imperforated hymen or a cervical dysgenesis or a transfer of vaginal septum, or it could be just a Müllerian agenesis.
Very good.
The other things that come to my mind, depending on the presence or absence of breast or the other sexual characteristics, could be androgen insensitivity syndrome. So if it's present and pubic hair and axillary hair are absent, then I think about that. The other things that come to my mind similar to this case is primary ovarian insufficiency. If secondary characteristics are absent, it could be also hypoamenorrhea, so meaning that hypothalamic amenorrhea is leading to a cause, especially people who are like have a lower BMI or have like the athlete triad as well. It could be other endocrine disorders, so usually check for prolactinoma as well as thyroid disorders.
Okay. If we, just to cone down a bit, if we were working with somebody who had apparent primary amenorrhea and underdeveloped secondary sexual characteristics, how would you pare down your differential diagnosis list now?
So with the absence of secondary characteristics, we know that probably the estradiol level is low. So in that case, it'll be more towards the hypoamenorrhea, primary ovarian insufficiency, um, um, and things like that, or like Turner syndrome, really, rather than going towards like the structural causes or the androgen sensitivity.
Good. Okay. So you said you had an MRI that showed a small uterus and appeared to show bilateral gonads, which were in the position of ovaries. Is that right?
Yes.
Great. So based on that, what testing would you now undertake to determine more what might be happening here?
So, although there is a uterus and bilateral ovaries present, always there is a chance for gonadal dysgenesis and presence of a Y chromosome. So always check karyotype in these circumstances. Check an FSH and LH level, as well as estradiol and progesterone.
Okay. And why is it you're looking for the Y chromosome? Why is that important?
It is important because if there is a gonadal dysgenesis present, depending on the situation, we want to proceed with gonadectomy because that increases the chance of neoplasia and malignancies in the remaining gonad.
Okay. What sort of gonadal dysgenesis syndrome could actually contain a Y chromosome, though?
It's Swyer syndrome.
Mm-hmm.
That could have that, and also I believe 5-alpha reductase deficiency.
True too. Okay. Anything else we should be thinking of?
Also the androgen sensitivity syndrome, obviously.
Okay, that sounds good. So you said this seems to be, you said it was it primary or secondary ovarian insufficiency? Did you determine which one it was?
So obviously because she hasn't gone through puberty, it is good to know if it's something that damage that occurred at birth in utero or it was afterwards, but our diagnosis with her, because we didn't come up with any like immunologic causes and things like that, we called it a primary ovarian insufficiency.
Did she have a karyotyping performed?
Yes, it is. She was.
Okay. So what sort of things then could cause primary ovarian insufficiency in a woman who I'm assuming has an apparently normal 46XX karyotype?
It could be different causes, including, we already ruled out genetic abnormalities, but it could be immunologic causes. So if there is, like, we always check for like thyroid antibodies as well as adrenal and ovarian antibodies and make sure that there is no immunologic reason, but also check for, any history of like chemotherapy or radiation therapy as a child, because that also contribute to that, or like toxin and environmental factors could be a reason as well.
Okay. So how then would you manage this young woman? You've decided apparently she does have primary ovarian insufficiency at 16.
Yeah, so with her, obviously we started a hormone replacement therapy with the goal being to assess development of the secondary sexual characteristics. So we initially started her on estradiol for 3 months initially, and then a combined treatment of estrogen and progesterone to induce menses.
How do you determine how much hormone to give her then? If she's 16 and her body has never really seen these hormones before, and you said you actually want to produce secondary sexual development.
Right. So you said how long will I keep her on HRT?
No, how do you determine how much to give her and what to give her?
So because she's still in the age that she has like bone mass development going on, we choose higher doses that we normally do for our postmenopausal patients. So in this case, we started her on estrase, which is basically estradiol, 2 milligrams 3 times a day, so 6 milligrams daily, and initially to help with the breast development, like I explained, and then added medroxyprogesterone and cyclic medroxyprogesterone to it. But basically, after you have, induced the breast development, you could potentially put them on OCPs as well. Not necessarily low dose OCPs, but maybe the higher doses, 35 microgram dosing.
How would you counsel her about her sort of lifetime risks or just her medical concerns for her over the course of her lifetime related to this diagnosis in general?
Mainly, what we always counsel these patients about is the risk of developing early osteoporosis. So always counsel on calcium and vitamin D supplementation, as well as necessity of compliance with HRT, because basically lack of those hormones can have a significant impact on cardiac health and also lipid profile as well.
How would you counsel her about cardiovascular risk?
So her chances of basically having like a myocardial infarction or MI would be increased compared to her peers if she is not, again, compliant with her HRT. But
if she is in compliance with her HRT consistently, would you still counsel her that she's an increased risk or not?
I would say no.
Now we go. This is the oral exam. Even though we're just practicing, are you guessing, or are you telling me this on the basis of firm information that you feel confident about?
I feel confident about this since we are starting her on replacement. Increase her chance of having myocardial infarction as long as she is compliant with the patient.
Okay. All right. At this point, the examiner will say, how does hormone replacement therapy compare with having endogenous hormones throughout your lifetime? Is it equivalent?
That is a very good question. My answer to that would be probably yes.
Well, not in the way that we'd like it to. I think the important thing that the examiners would want to hear, and we want to always be conservative and cautious in the exam. So if this is the point where you need to say, I don't know, I would absolutely say, I don't know. Because once you're on sort of shake your on, you're not really certain of yourself, they'll keep digging in with the questioning. But the issue, I think, would be that menopausal hormone therapy in women who are menopausal certainly does not replace endogenous estrogen. It's a partial replacement. And here we're trying to develop secondary sexual characteristics, and then you're going to develop stable lifetime therapy. But it's not, I don't believe it's necessarily the case that we actually are completely replacing endogenous hormones to the level where the body can't tell the difference. So I think we might want to be cautious and say it is certainly possible that she may have an increased cardiovascular risk across her lifetime because relative to what her body would normally be given, she may be getting some proportion of that, but she may be, relative to what her body would do cycle by cycle, slightly hypoestrogenic during her lifetime.
Got it. Thank you.
So, I'm telling you just based on what I understand about that. But since you're defending this case in the exam, I would be sure to have a good answer for that, because I'm certain that they're going to ask that, because this is obviously an REI case that's sort of you're well prepared to discuss. From the generalist standpoint, they're going to approach this from the standpoint of let's think about how menopausal hormone therapy works, and how does this compare, and sort of what's our knowledge base on that, and how do we translate that to this particular woman there. So I would expect them to come at it from that point of view.
Thank you.
Cool. All right. Well, how is that so far? I think we covered a lot of what they would probably cover in this case, and they wouldn't spend more than about 3 or 4 minutes on it. Is there any aspect of this that you would like to talk about, or that we didn't touch on, that you think would be important as we were going through that?
Not really. I think that was. Thank you so much.
I think you gave a good defense of that case, a good description of the management. I think you're in good shape. Just remember, when you get sort of 5, 6, 7 questions in, it's getting more and more and more and more kind of picky and specific. You can bail at any point. The pass-fail stuff is usually the first 2 to 3 questions in any case, and after that, it's just sort of seeing how much you know and just sort of running until you run out of things to say.
Okay.
That's the tactic. Thank you very much. Let me get, let's see. I think we had Ashley and Maria here. I think Maria was offline, but I think she may be coming back. Ashley, I'm going to try and pull you up here for a minute. There you go. Hey, Ashley, welcome back.
All right, thank you.
Hey, let's pull up your case list here. Anything particular you'd like to talk about this evening?
You know, I think we did OB the last time, so if we could do office or GYN, that would be great.
We'll see. We'll go office here, maybe. Let's see. Sure. Anything you've been looking at that you'd like us to pick out while we're just checking stuff out here?
I will let you pick.
Okay, let's see. Let's get down here. Let's see. Oh, there's more ovarian insufficiency. We'll steer away from that just for the moment. Let's see. Great. Can we do case number 14?
Okay.
I'm picking it at random. 25-year-old, null-gravid vulvovaginitis, Leucasia candida. If she is 65 years old and she turns up in your office, this is what the examiners do with these office cases. 65 years old, worsening vulvovaginal pruritus over the course of several weeks or so, and hasn't been able to get an appointment until now. What would be a basic differential diagnosis in a case like that?
Sure.
In a 65-year-old.
In a 65-year-old, I would think of yeast infection, I guess BV,
Okay.
but I would be more concerned about like a lichen sclerosis, a lichen planus, contact dermatitis, and typically also intertwined in there is a genitourinary syndrome of menopause as well, if she's not on vaginal estrogen.
Great. So if your examination showed simply sort of diffuse sort of skin sort of thickening and mild inflammation and a bit of leukoplakia sort of around the clitoral area, upper labial area, how would that define your differential diagnosis further?
So the thickening is probably due to the scratching. So that's going to be your basically like an eczematous process. The leukoplakia about the clitoris, I would be a little more cautious about because, as you know, a whitening could certainly represent a lichen sclerosis. And with lichen sclerosis, it is, I do like to get pathologic confirmation of it, just so we can prove it was there and we know what we're treating, since the treatment for a lot of these conditions is the same. It is corticosteroids. But so having it be a clitoral area is a very sensitive area for biopsy.
Yeah. So if the treatment for so many of these conditions is the same with corticosteroids, why do you feel it's important to get a biopsy before we start treating it?
Because with lichen sclerosis, particularly, I counsel my patients, there is a risk of transformation into squamous cell carcinoma if it goes untreated or undertreated.
Got it. Now, is lichen sclerosis a pre-malignant condition of the vulva then? Is that what you're saying?
I suppose you could say that. I would call it a very pre-malignant, and for that reason, it is important to stress to these patients that they will probably need like a lifelong treatment with corticosteroids, probably not every day, but that they need to continue it for forever and not just for a couple months.
Oh, got it. Okay. If she has lichen sclerosis and she is HPV negative, is she at increased risk of developing vulvar carcinoma?
Yes, because those are different. That would be because the squamous cell carcinoma that arises from lichen sclerosis is the differentiated type, not the usual type.
Okay.
Which is associated with HPV.
Okay, so are you going to biopsy her first or treat her first?
So I would biopsy her first. You'd have to take a lot of careful consideration in doing the biopsy, of course, but yes, I would biopsy her first.
Good. What kind of biopsy do you do?
So on non-clitoral areas, I typically do a punch biopsy.
Okay. So since it's in the labial area, let's go with that. Good.
Okay.
If your histology comes back VIN2, how would you counsel the patient about that and how would you manage that?
Yes. So for VIN2, I would call that a pre-malignant lesion.
Yep.
And note that it does need treatment. Options for treatment can include excision surgically. There are also physicians that are capable to use laser. and others, I believe, have started in certain situations treating with the imiquimod, but I believe that is off-label.
Okay. Is there anything else you might want to do as far as a evaluation at this point with this diagnosis?
Well, certainly if you just did the biopsy and it came back
Yeah.
VIN2, you would definitely want to do a vulvar colposcopy to see if there are other areas that are affected.
Got it. Well, you can see that there are others areas affected. How would the colposcopy help you in this case? Because you're seeing the lichenoid changes. You apparently biopsied a place that you thought would be high yield, and you got VIN2 on that. How does the colposcopy help you specifically?
That is a good point. So typically, we would do a vulvar colposcopy for something that was more HPV related, because the application of acetic acid can be very painful if you have a lichen. However, the colposcopy definitely lets you see the degree of changes.
Yes.
And, to say, is this already looking more like a invasive cancer? Is it high grade looking? Is it low grade looking? So you can further offer counseling to the patient and figure out.
Yeah, I agree. The examiners are sort of, their job is to challenge you. Your job is to defend. That was a good defense. You should definitely do a colposcopy too. You may see something under colposcopy that you want to biopsy that might in fact be a more severe lesion. All we've got is one sample of this area that happens to be in the VIN2 range, but there may be a spectrum of VIN there. So if you find another lesion via biopsy it and it is returned as invasive squamous carcinoma, how would you counsel the patient, and what should be the next step in her management at this point?
The next step in her management would be referral to a gynecologic oncologist definitely for counseling on how to treat it, which is going to be excision, and they can decide together the best manner of excising that particularly, and any further treatment that would be needed after.
Yeah. What would be maybe a common way of managing this diagnosis in a 65-year-old? No, what would the gynecologist generally recommend?
Generally for an invasive squamous cell carcinoma, it would be excision and probably a lymph node biopsy.
Yes.
And then depending on, I imagine after that, looking at the pathology, she would need close follow-up with examinations, I believe every 3 to 6 months for the first few years.
Okay, when you say excision, what procedure are you referring to here? There are a number of ways that we could do this, I think.
Sure. So this would be called, I know they're trying to be a little bit more conservative now to do a partial vulvectomy as opposed to a total.
Yes, good. And you mentioned lymph node dissection. What lymph nodes in particular are we looking at in this area?
They'd be looking at the inguinal lymph nodes.
Okay, right. Any particular types of inguinal lymph nodes, or any particular class or chains in there?
I'm sure there are, but I think that's beyond my reach.
We're good. You've done a beautiful job with this case. That's perfectly okay. You bail at the point that you want to bail. This is not the G1 Oncology Boards. That's perfectly okay. But if you want to get one point more further, and we learned this in medical school and also in residency, and we don't do it much. We don't use it much out of practice, but we do have superficial inguinal lymph nodes and then deep inguinal lymph nodes. And just like in breast therapy, we're always looking for the sentinel node on the breast. In vulvar carcinoma, the sentinel node usually would be Cloquet's node. That's sort of the gatekeeper between the superficial and the deep inguinals. So if they ask you, I would say superficial lymph node dissection, they probably try to identify Cloquet's node while they were there, if they could, if they're really doing more of a major procedure. But you don't even have to go that far. You've more than passed this question at this point. They would be very happy to move on to something else at this point.
All right.
Yeah, nice. I mean, this has nothing to do with this case on your cases. They just took it in a different direction. You stuck with it, and you gave a really nice defense all the way through. That was very nicely done.
All right, great.
Good work.
Great cases.
Thank you again. Thank you. That was great. Let's go back down to Maria, and then I think we have Asra and Ebony coming up. Maria, hi. Can you hear us okay?
I can. I have spotty internet, so if I go offline again, just please move on. I apologize.
We got you really good right here. Let me just go grab your case list here right here. Anything particular you'd like to talk about this evening? It's your choice.
No, I mean, we can do OB or office.
Okay, let's see. We've done office or maybe let's go OB. Just to see. Anything you've been looking at just this past week that we should check out with OB?
No, nothing specific.
Great. We always try to pick something on the first page of the case list because it's easy to talk about. Let's do case number 3. For good, right here, 28-year-old, gravity 2 per 0, 38 weeks, decreased fetal movement, and then she had some other stuff that we found out as well. Let's see, that's just 38 weeks, right? Let's see, so decreased fetal movement. If she shows up at, let's say, a 38-week appointment with a report that she's just not noticed the baby at all move as well in the past day and today than usual, and she's very concerned about that, what sort of things could be involved here before we even get into doing a history and examination with her? Let's develop a brief differential diagnosis of that report at a term pregnancy in a primogravid patient.
Of decreased fetal movement?
Yeah, just subjective decreased fetal movement. Yep.
Just maternal lack of awareness of fetal movement. It could be placental insufficiency. It could be any sort of maternal comorbidity. I guess I'd be thinking more like chronic hypertension or hypertensive disorder of pregnancy, or possible diabetes of any type, gestational or pre-pregnancy. Perhaps there was some sort of injury. Perhaps patient was involved in sort of an accident. She had fallen or was in a car accident. You know, at worst, I'd be thinking, you know, IOFD, which could be the worst, I guess, outcome. It could be, as she has on this case, oligohydramnios preventing, I guess, fetal movement, or, you know, she ruptured, therefore that's why she has oligo.
Anything otherwise important we might want to consider? We're developing a pretty nice list.
Anything in regards to decreased fetal movement?
We touch on a lot of things that sound like they're placental, because you said there could be placental insufficiency, and then you named some maternal conditions that probably would be involved with placental insufficiency, and then you mentioned oligohydramnios, which is another sign of placental insufficiency. Anything else that could be going on sort of intrinsically to the placenta that we haven't talked about that maybe we'd want to keep in mind? It'd be more on the severe spectrum, but just when we're making a differential diagnosis.
I mean, I guess I'd want to be thinking infection in the back of my mind when I'm taking physical, especially right now with COVID, but I'm not sure how that would correlate. Any inherent, I don't know, I guess I think I might be reaching and digging myself a hole at this point.
Okay, yeah, don't do that if you don't go there unless you want to. Anything just about the placenta that might be abnormal or might be developing that would probably want to know about if it were happening.
Oh, so like any sort of like abruption is what you're thinking?
There you go. That's exactly, yeah. I mean, we brought up FDIU, which is the most extreme. Then we're working back toward, so serious placental disorders, abruption, stuff like that. Good.
So I have to say, I've seen this in the Exam Pro lecture series. I've seen FDIU, and I actually don't know what that stands for. I hope I'm not alone, but I wasn't.
Oh, no, fetal demise in utero, FDIU. Or gotcha. IUFD is intrauterine fetal demise.
Gotcha. Yeah.
Either way. Okay. Good. So if you were concerned about, just based on her history, maybe she'd been seeing a little bleeding or spotting, how would you evaluate for a possible abruption in a setting like this? Let's say you have her, let's say in the hospital in the triage area. We'll make this easier so you've got lots of resources available.
So obviously I would start with the history and physical. I would do a pelvic exam, do a speculum exam, look to see if there's any bleeding in the vaginal vault. And do a cervical exam if I knew where her placenta was located and know that she does not have a previa. And then I would proceed with an ultrasound.
And what signs on ultrasound would you be looking for? What might be signs of a early abruption, or maybe a chronic abruption that's progressing?
I've always been told that, you know, an abruption is about 50% chance of seeing anything on an ultrasound, but you could potentially see a hypoechoic area between the uterus and the placenta, if I'm saying that correctly. And that's really all I know that you can look for that would be any sort of signs of a placental abruption. Certainly after the ultrasound, you'd want to get a non-stress test or monitoring on the baby and look at the heart rate pattern.
Good. It's a good answer. Ultrasound diagnosis of abruption is not reliable. You're right. It's very often you don't see anything specific. That's absolutely right. And you're right. You could see a retroplacental collection or something asymmetric about the placenta. Sometimes you actually can see a detachment of the placenta with something behind it. That's usually something fairly acute. So if you got a, did you say you're getting a non-stress test on her or a biophysical? I forget which one were you going to get on her?
Well, if we were doing the ultrasound, I'd do a biophysical just because you have the
Okay.
ultrasound ready,
Okay.
and
All
then
right. Let's
proceed
see.
to the non-stress test.
Sounds good. Let's see. So if her biophysical is 6 out of 10 and her non-stress test shows repetitive late fetal heart rate decelerations with a normal baseline, what would you do at this point?
Well, I would be thinking in the back of my mind that I'm going to be probably moving towards a C-section, but I could try, because we have a normal baseline, you said, I'm assuming that means moderate variability. I would try fetal resuscitation measures such as getting IV access, giving the patient IV fluids, considering position changes, and to
If the
consider.
pattern worsens despite that, what would you do?
I would alert anesthesia and nursing and say that we'll be moving towards the delivery, or excuse me, the operating room to proceed with the cesarean section.
Good. Are there any preparations that you would want to make as far as resources or just things available if you are doing now an emergency cesarean section in the setting of your concern that you may be dealing with an impending acute abruption?
I would be thinking that blood loss would be higher than normal. So I would make sure that she has 2 18-gauge needles. I guess we could be considering, getting the blood work type in screen or type in cross for whatever it is that I think my concern is. I wouldn't be calling a massive transfusion protocol yet, but maybe it would be a good idea to alert the blood bank that would be a consideration.
Very good.
Let anesthesia know.
Yes. What labs would you like to order right now?
If I'm concerned for an abruption, I usually get a CBC, type in screen or type in cross, and then coags, PT, PTT, and fibrinogen.
Good. That's nicely done. How intraoperatively, how do you manage a couvelarie uterus?
That's a great question.
But you can't, don't ever say that in the exam, because it's okay to do that because we're practicing. But
Yes.
the reason you're getting this question is because you've done so well with the entire case. The examiner just has to push you over the edge at some point.
Okay, so I guess I wouldn't manage it any differently. I would just proceed with my cesarean section and then assess the tone of the uterus afterwards and move forward as I would any other procedure.
Okay. What is the general management of a couvelarie uterus following delivery of a baby, which we hope would be alive?
I don't know that the management would be any different other than assessing tone and blood loss.
Okay. Well, can you describe for what is a couvelarie uterus?
As a best attempt at describing this, I believe it has to do with a blood loss into the myometrial layers.
Exactly. Yes,
and
it's a uterus that is grossly distended with inspissated blood diffusing into the myometrial tissues. Yes, it's one of the worst things you can ever encounter. So in that particular, given the way you've described that, is there a possibility of salvaging such a uterus?
I'm inclined to say that there is.
Not generally. This is now the patient
Really?
is definitely now the patient is probably going into DIC, and the uterus is questionably viable. This is it's a dire situation.
Okay.
So
then you would have to perform
in the examination, I think I would say that this is one of the worst situations possible. The patient is at imminent life-threatening risk right now. Couvularie uterus is a dire emergency. You can say it is most likely that she will require a hysterectomy, and just leave it at that. And they'll be happy to just leave it and go on.
And you don't try your B-Lynch, you don't try any of the uterotonics.
This is a uterus that is distended with blood inspissated into the myometrial tissues. There's no compression. This uterus is hard as a rock, and anything you do to it is going cutting into it to do the C-section, there's risking massive hemorrhage. Any operation on this uterus other than taking it out is a risk serious hemorrhage. We've already got the DIC developing, things like that. It's a uterus that is just it's rock hard, and it's just all blood through there, and it's not really salvageable.
Okay.
But as I say, that's okay. They could take you there just to see, and you sort of do the best you can. That's perfectly okay. The discussion of how you'd manage the really important stuff, which is decreased fluid moon, differential diagnosis, concern for what could be going on that's more serious, how you'd manage someone with a concern for abruption, that was perfect. We're good.
Okay.
We're happy.
Thank you.
Thank you for sitting through that. Let's go to Dr. Joe White for a minute. Asra, trying to get you unmuted here for a moment. Let's see. I think it says you're self-muted. I'm going to try that again, see if we can get you undone here. Asra, there we
Hello?
go. I think we got. All right, Asra, hi, we got you. Can you hear us okay?
Hi, yes, I can. How
Hey,
are you?
thanks for joining us. Fine, thank you. Let me get. Let's see. We
I
don't
don't
have your.
think
Wait,
my case list might have been updated. I sent it in a
that's okay.
little late as well.
They'll be getting to it, but that's okay. We will be happy to talk about anything you'd like to. If you have your case list there and you'd like to present us a case, that'd be great. If you want us to just do something sort of off the cuff, we'll do that as well. You're in the
Um,
driver's seat, so I will do whatever you'd like to do.
sure. Well, I seem to have a lot of contraception management
Oh, okay, good.
in my case list, so
Uh-huh.
I guess we can go for that.
That sounds good.
Um,
Good. Sounds
okay.
perfect. Let's
All
see.
right.
Do you have a case particular? Or do you want me to just make something up?
No, just if you want to just go for
Just
something.
wing it? Okay, great. All right, let's see. So a 22-year-old nodal gravid patient comes to see you. She is engaged to be married in 3 months. She has never been sexually active and will not be sexually active with her husband until after marriage. She knows little about contraception, but she is interested in discussing effective contraceptive options because she does not want pregnancy anywhere in the near future. How would you discuss contraceptive options with this particular patient, and what would be your thoughts as to maybe what a reasonable contraceptive option might be for her?
So I like to do a history and physical, well, a history mainly
Yeah,
when
yeah.
I have these patients, um, mainly to figure out how their menses is, whether it's heavy, painful, things like that. Or also, I would like to figure out if she has any other comorbidities that may be preventing her from having certain options.
Hmm.
Um, and then I kind of go from there.
Okay,
I usually,
sounds good.
okay.
Go ahead. Go ahead.
So if everything is normal and she doesn't have particularly heavy menses and she doesn't have any contraindications to specific methods such as I'd say like a history of any kind of VTEs or any history of migraines with aura or hypertension. As she's young, she probably does not have these things.
Hmm.
But sometimes you still find patients that do. So I do always ask about those comorbidities. And then depending on that, I will counsel them on. I usually start with my risk of pregnancy and then things like barrier methods we go through.
Hmm.
And then we also go ahead and talk about progesterone only methods.
Hmm.
And then I move on to combined oral contraceptives or estrogen only
Hmm.
methods. And then it essentially finish off with my long acting reversible contraceptives, which I highly encourage if they do not have any contraindications to it.
Oh, good. So in someone who is virginal and who has little
hmm
knowledge of this sort of thing, what might you suggest to her as a contraceptive option, since she probably is not going to have any particular preference? And
I
the
usually,
important thing is that you want something that is going to be reliable for her. She doesn't want to become
right.
pregnant, and something,
Okay.
something that she can understand and use, and something that will reliably prevent pregnancy.
So I usually will err towards things like the Nexplanon or a progesterone implant.
Hmm.
And then also things like our Depo-Provera shot, which is um, every 3 months.
Hmm. Okay. If she discloses in her history that her mother actually had a pulmonary embolism just after delivering her, has recovered and is okay, would that in any way change what you're thinking about here?
No, not particularly.
Okay. Is there any particular further evaluation that you want to consider doing with her? Or perhaps not?
Um, Unless, and I think I would maybe ask a little bit more detail about her mother's situation and
Mm-hmm.
see if they had discovered if she had any kind of clotting disorder or thrombophilia.
Sure. If she discloses her mother actually did have some testing, and she said she had something hereditary that caused her blood clot, but she doesn't really know what it is. Would this in any way influence your consideration of contraceptive options for her?
Well, I would probably err on the side of advising her to go with progesterone only methods or uh, in comparison to really thinking about estrogen,
Okay.
like COCs or
Mm-hmm.
NuvaRing and whatnot.
Okay. All right, let's see. If she elected, just because you want something shorter term to try it out and see how it goes, maybe a Depo-Provera injection, which you administer,
Mhm.
and she calls you 4 weeks later because she's been consistently just sort of having light spotting or bleeding every single day since her injection. How would you counsel her? How would you manage a situation like that?
So usually I do counsel them before with progesterone only methods, especially Nexplanon or Depo-Provera. There is a pretty significant risk of breakthrough bleeding that can
Yeah.
happen,
Yeah.
specifically the first several months that you have it.
Mm. Hmm. So she's going to be married in 3 months, and now she's going to be married in 2 months at this point.
Mhm.
How would you manage that situation?
Sometimes I encourage them to use NSAIDs at times,
Hmm.
ibuprofen, see if that helps alleviate any of the spotting, or supplemental progesterone, or a short course of
Hmm.
OCPs as well can be beneficial.
Would you be okay with giving her OCPs, given the history that she has just imparted to you?
Yes, if it's a short course.
Okay. Um, if she tries the OCPs, the bleeding resolves, and she decides she'd much rather do birth control pills, how would you proceed in this instance? And then we'll
If
let you off the hook after this.
um, I think so I would probably want to do a little bit more workup for her initially before
Okay.
prescribing
Hmm.
her
Good.
some.
This is where we've been going for about the past 5 minutes, and that's perfectly okay. I'm just sort of pushing to see if you'd think about maybe doing a thrombophilia workup on her or not, given that maternal history. And you decide to
Right.
go with progesterone-only options, which is perfectly reasonable. Although we do have to keep in mind, if we talk to our hematologist, when we're dealing with DVTs, that's sort of a non-aggressive type of VTE event. Pulmonary MLA are much more aggressive. They are more associated with thrombophilias, and the
Hmm.
hematologists, and there's some suggestion that progesterone-only contraceptives, especially Depo-Provera and things like that, may actually increase the risk of a more aggressive VTE event if there's a tendency to that. So the
Okay.
hematology community is a little bit more careful about that than we are. That might be something to keep in mind. Right,
Okay.
and I was just, and you were absolutely in your rights to try something progesterone only. When we do that, we sort of want to think ahead, when we're doing something, because the
Hmm.
breakthrough bleeding is a common cause of that, and think about if that happens, where would I go? And if the thought is, well, I'd probably give her something like a combination OCP, maybe we should beforehand do some simple testing first. That sounds perfect. So then last question, you're done. So what would you test her for then, given her mother's history and that you decided you'd now like to do a workup with her?
So things for inherited thrombophilias would be um, factor 5 liden,
Hmm.
antithrombin 3,
Good.
prothrombin gene
Yep.
mutation. I can't
Uh-huh.
remember the numbers.
That's okay. Don't worry
Um,
about it. That's
I
fine.
think those three are probably the highest. I think some of them still do the MTHFR gene.
Yeah. No, no, don't
Um,
don't ever need to. That one we do not need to know. That's okay. But you're right.
okay.
The Leiden factor 5, prothrombin 20210, I think is what it is. Antithrombin 3, probably the most serious one. Um,
Mhm.
any thought of antiphospholipid antibody testing with her?
Well, I guess that is another one that you can do, but that's more if you have a history of specific types of losses or,
Hmm.
um, and that's more of an acquired.
Hmm. Can be
rather than
acquired
inherited.
or can be inherited. And it is, along with
Okay.
antithrombophilia, it is one of the more serious ones. They can have both arterial and venous thrombosis. So it's never a bad idea to just check for that. You can always throw that on the
Okay.
list. Protein C and protein S, maybe, but I think definitely if you're looking at inherited ones, I would think about that. You might think about maybe APLS. Good.
Okay.
All right. So how did you feel about this case? Just about how the discussion went and sort of where we took it. Were you thinking in any other direction, or is there anything about the case you'd like to discuss? Because you can be the chair.
I think my question would be, should I have mentioned doing or should I have mentioned doing testing for inherited thrombophilia sooner? I guess.
Well, if you have a patient who you're thinking about contraceptive options, she gives you that history, which is actually it's a first degree relative with a PE, and you're thinking about sort of this woman is going to want to have contraceptive options over a lifetime. If she hasn't had it looked into, maybe now is the time to do it. But you're within your rights to think about trying a progesterone only method if she would just like to start trying something now to see. Sort of thinking, planning ahead if she starts to run into problems with it. We do quite often do some sort of estrogen add back with OCPs, and then that gets into sort of when do you want to test her? So you can go either way. The examiners are just trying to see sort of how you were thinking through the process. I think you're perfectly fine. But that's one of those things. In the exam, if they start to bring up stuff like that sort of history, it's reasonable just to say it's appropriate to do a thrombophilia workup since this woman's never had hormonal therapy before. She's now interested in very long term. We might want to find out a little bit more about her. Yeah.
Okay. And then is there anything specific that you would suggest to mention for things like breakthrough if that comes up?
You can, the simple thing might be just to give her 4 weeks of a low dose combination oral contraceptive, which quite commonly covers it over. And then you do sort of you're going to have to wait 3 months for the depot cycle to wear off and then maybe try something else. And that sort of runs into her wedding. So it's all about sort of, it's counseling and planning out. But as far as short-term management, I think what you described is exactly right.
Okay. Thank you.
Sounds good. Thank you. That's nice. Let's get to Ebony, and then we have Dr. Tran also, I think, raised her hand. Ebony, coming to you in just a moment. See if I can get you unmuted here. Oh, there we go. I think we got you. Let's see. Ebony, are you there? Hey. Hi, Ebony. Can you hear us?
I can.
Oh, good. Thanks. It's just bringing up your case list. There we go. Thanks. Thanks for joining us. Anything particular from OBGYN or office that you'd like to look at this evening?
Nothing in particular. I think we did GYN or office last time, but I'm open to whichever. We can do anything.
Okay. So well, let's go OB then. All right, let's go way down your case list and find something down here from OB.
Oh joy.
That's okay. We're just looking. How about case number 70? We can do this in the time allotted and still have a little bit of time left over. So 24-year-old gravid 2 pair 1, no prenatal care, 39 weeks gestation. So this woman shows up, you're the house doctor, you're accepting unregistered patients. She shows up this morning, Sunday morning, no prenatal care, reporting that, she thinks she's maybe around 9 months pregnant or so. And an otherwise apparently healthy person. What important things would you want to establish as quickly as possible when this patient walks in with no prenatal care at term, and she came in because she's having contractions and she thinks she might be going into labor?
So definitely wanting to establish how far along she thinks she is, when her last menstrual period was, if she had any ultrasound at all in this pregnancy. Then trying to establish her age and if this was her first pregnancy or if she's had prior pregnancies before and if there were any issues in that prior pregnancy, whether it was a C-section or any infections, et cetera, that we are concerned about in that prior pregnancy.
Good. Let's go back to that. She's had one prior pregnancy. Let's assume it was perfectly normal, but it was maybe 4 or 5 years ago or so. She thinks her menstrual period was, within about a 2-month range, but she's not really sure. She's not had any prenatal. She's not seen a doctor at all during this pregnancy for anything. How would you go about then trying to establish gestational age for her and figure out how she should be managed?
I would do a quick fundal height or Leopold's on her just to kind of estimate how large I felt baby was. And then I would do a bedside ultrasound.
Good. Okay. And what are you looking for on the ultrasound?
I would be looking to measure the head circumference if possible. She's likely in labor, so that'd be difficult. But I would also be looking to measure the abdominal circumference as the measurement to help me assess how far along she is.
Good. And how did those measurements help you in determining gestational age?
How do they help me?
Yeah. So you're measuring those circumferences. How do those translate into helping you to establish a gestational age?
I guess so. With the head circumference, the abdominal circumference, as well as the femur length, and the BPD, I would. I don't know the exact calculation, but I would.
No, the computer does the calculation. You do not have to know the calculation. This is just the questions on the exam are very commonly stuff that is just so simple and obvious that you don't know how to answer. But the correct answer is those measurements actually, according to an algorithm the computer uses, can be used to calculate an approximate gestational age.
Okay.
That's your answer. I mean, that really is it. It's the Hadlock criteria, of course, is what the computer usually uses in the ultrasound machine. But it's those measurements sort of there are standard ranges, sort of plus or minus 2 standard deviations for every week of the pregnancy, right? For BPD, HC, AC, and femur length, and that's exactly what it is. And you don't even have to get that detailed in it. It's just those measurements are used to calculate a composite estimated fetal weight and gestational age. What's the standard error then, if she really is at term pregnancy on these measurements?
I believe it's greater than 30 days in the third trimester regarding the ultrasound.
You can go about plus or minus 3 weeks is according to the most recent practice poll, and it's pretty good. Now that obviously varies greatly from community to community depending on who your radiologist is or whether we're doing it or somebody else is doing it. But about 21 days is reasonable at term. So if you've written it down here as 39 weeks and there's a plus or minus 3 week error, what's our gestational age range that we're working with here?
Anywhere from 36 weeks to 42.
Exactly. So then very briefly, is there any other information you might be able to get from her that might help to tighten that anymore? And she's had no prenatal care, has never seen a doctor during her pregnancy.
So she said when she thought her last menstrual was, or I guess asking
within a 2-month range, which is sort of doesn't help much because you're dealing with a 6-week error range on your measurement right now.
And she's had no ultrasounds or no Doptones or anything like that?
No, nothing like that, nope.
Yeah, I'm not exactly sure what else I would, other than asking her how regular her menses were outside of pregnancy.
That's one very good question. You should definitely mention that to the examiners. And then, of course, it is about, did she take a home pregnancy test at some point and it turned out that she was pregnant? Then we're working up then, did she have fetal heart times by Doppler? She did not. The next one up would be, did she notice at some point that she felt fetal movement?
Okay.
Which if you're looking at a 6-week range and she can tell you a date at which she did, we're thinking now maybe 17 to 20 weeks or something like that. So that halves your error range possibly. It's one more way of talking about this. So it's really what the practice bulletin says is a third trimester ultrasound plus any history that you can get can give you a reasonable estimate. And that's what we're talking about here. The examiners would want to hear, the error range on your ultrasound, and then what could we get from the history? And you sort of work from the beginning up, menstrual period date. Next up is when she got a home pregnancy test. Then did she have a ultrasound? Did she have a Doppler auscultation? Did she notice fetal movement? That's sort of the chain up as we go through the pregnancy. So if we think, though, she really is between 36 and 42 weeks, and she seems to be going into labor. Anything else, just very briefly, because I do want to get to our other candidate, anything else that's really important to know about her if she's being admitted for possible labor and delivery? She's had no prenatal care, don't have any other studies or information on her.
I would want to know if she was GPS positive in her prior pregnancy.
Okay, good. That sounds good. Anything else you want to know about? You can order tests.
I would get all of her lab work done and then know if she had whether she had Hep C or any Hep B or HIV.
Okay. How long does it take you to get an HIV test back if you order a standard HIV ELISA on her?
It's for our hospital, it's a rapid test. We would find out the same day.
Right. So you're doing the rapid, you have to tell the examiners, you're doing the rapid HIV RNA test. You're not doing the standard HIV screening test. That's exactly right. You get that back within an hour, probably. Good. Hepatitis B, hepatitis C, how long does it take you to get those back?
That takes us some time. Typically,
some time.
It's a vaginal delivery, we find out after.
Yes, exactly. Is it critical to know that before the baby is delivered, Hep B or Hep C?
It would be nice to know.
Yeah, but if we didn't know until 8 hours after delivery, would that be a problem?
I think that would be fine.
Abby, if we didn't find out if she was HIV positive until 8 hours after delivery, would that be a problem?
Yes. Well,
Yes.
depending on
Why?
the
Yes.
route of delivery, yeah.
Yes. Why would that be a problem?
Depending on her status and her viral load, it can
Exactly.
vertical transmission is increased.
Exactly. Yes. Exactly.
Her
Yes. And we want to give her interpartum antiviral medication as well, but we also might want to section her. Exactly right. Yeah, we could do vertical transmission for her could be somewhere around 20%. We could bring it down to 2% if we did everything right with her. That's a huge difference for the baby. Absolutely. Very good. Nicely done, Ebony. Any questions or anything before we move on? I'd like to see if we get Dr. Tran in before we wrap up for the evening.
Nope, I think I'm good.
Good. That was nice. That's just, remember, this is the really basic stuff. This is, I mean, it's sitting right here at the bottom of your case list, but no prenatal care is something that gives the examiners the chance to start from the very beginning and just sort of understand the basics of how we approach sort of, the basic stuff. It's establishing how far along, what's a reliable gestation age, what's a reliable EDC, how do we manage things when we don't have that basic information? It's really kind of entry level stuff. You did very nicely with it. Thanks. Let's go to Dr. Tran for a minute. Linda, I'm going to try and get you unmuted here for a minute, and I'll go find your case list for just a moment while we're working on that. Let's see. Linda's still trying to get you unmuted here. Hang on. There we go. Hi, Linda. Can you hear us okay?
I can.
Great. Thanks. I have your case list right here. We do, actually. It's right up at the top. Anything particular you'd like to chat about this evening? I have your entire case list right here.
No, anything. I have to say, I'm very impressed by everyone. This is my first case.
Yes, actually, this really is. We have had great candidates, and a couple of our candidates have been doing this last month with us also, so they're good. But yes, we've had excellent discussions. I think the entire evening this is going very, very well. In fact, since we started doing this in August, I've been very impressed as well. OB/GYN office, do you have a preference? Can we go maybe GYN, because we've done a bunch of office and OB maybe? Let's just see here. We'll do something we can accomplish in about 10 minutes or so, maybe. Let's see. Let's see. Let's see what we have here. Let's see, can we do case number 18? This is under SABs, which again, we don't think much about, but the examiners can always make something about it. Can we just case number 18, 20-year-old, first pregnancy, early pregnancy loss and embryonic. I'm assuming this is somewhere in the first trimester. Failed medical management. I'm assuming that they tried to do a medical induction for termination of the pregnancy. It didn't work. So now we're doing a section D and C. If you do your section D and C and you get back very minimal products, which just looks like a little bit of sort of endometrium being sloughed off and nothing else, in the OR, what would you do? You're expecting to sort of get it. You know you have an embryonic gestation. You know you got a gestational sac, a placenta, other stuff in there, and apparently medical management didn't work. You get minimal return on your section D and C. What would you do in the operating room to look into this?
If I had so I confirmed with my ultrasound before the OR, and I did see an embryonic sac. So
very good. Let's stop for a minute. That is the first thing you tell the. Let's go back from square one, because the questions are here. Did the patient pass the tissue, and you didn't actually check about it, or she didn't tell you, and you took her into the operating room for a procedure you didn't need to do? That's exactly right. You set the parameters of this case. By the way, I always check before in these cases before I come into the OR to be sure I've actually got something to treat with my section D and C. That was perfect. You passed the case on that one question right there. Go ahead.
Well, that's, yeah. Okay. So going in, I know that there is an intrauterine whatever, and if I don't see it coming out, perhaps like during the preparation while I'm scrubbing, maybe the nurse who did her perineal prep, and she passed it with that or something.
Yes, so right, you would ask. They obviously would tell you that, but yes, you would ask about that. Good. If none of that happened, it was a clean, did an ultrasound right on the prep room before you went into the operating room, clean prep, did the section D and C, very little is coming back. What would you do?
That's a good question. I mean, I don't have anywhere else to look if it wasn't in the uterus.
Right.
I wonder if she has, I mean, I would probably know this beforehand if she had a uterine anomaly. Like, am I thinking
how would you know that beforehand?
Well, when I'm doing the so assuming that, you know, I've seen this patient before, I've done a physical exam, I don't see like an extra septum in her vagina that would make me think like a
Sure.
didelphys, something like that.
Sure. Yes.
So I've already examined her, and I expect a normal anatomy, and in conjunction with the ultrasound, which you know would tell me if she had some kind of anomaly.
Okay, if you have a 8-week pregnant uterus and you're doing an ultrasound, you identify an SAB. Is it common to be able to identify a uterine anomaly at that time?
I suppose not, because it's small,
Yeah,
but it is
it's
possible that
possible, but not reliably so. You're right. So let's do a basic differential diagnosis. So it sounds like one of the things you're thinking of, and this is absolutely the right thing to think of, is that you went somewhere where the pregnancy is not, because her uterus is divided in some way, septum, bicornuate, whatever else like that. What else could be going on here? If it's not that, and she has a normal unicornuate uterus, or just normal unified uterus, what else could have happened here? If you went somewhere where the pregnancy was not, but it wasn't because she has a congenital uterine anomaly.
I mean, did I perforate? Did I go somewhere where I wasn't supposed to?
Did you perforate the uterus? Is there another possibility for going somewhere where you didn't intend to without perforating the uterus?
Like I'm watching myself go in through her cervical canal.
Right? You are, yes.
Okay.
So up to the external cervical os, you know where you're going, but we don't necessarily know where we're going past that point.
Yeah, I don't know.
Okay, no, we're good. So uterine perforation, congenital uterine anomaly, but this could be a false passage. You may not have perforated the uterus, but you may be off somewhere within the uterus that's not where the cavity is. And for reasons we don't understand. Those would be the basic. Outside of that, you're right, it would be that she passed the tissue and there wasn't anything there, but you obviated that by very appropriately pointing out that you do check your ultrasound before you go into the OR. Good. So, it's given that
Sorry. I guess I don't understand. So how would I have gotten into another path without like perforating, I guess?
Well, you could created a false passage. You could have sort of be somewhere in the myometrium.
Okay.
Less likely. That happens more with the DNC on a menopausal one, but it could happen if you're using like a 7 or 8 millimeter suction curette. It could happen. If you're using like the 12 or 13s, like we often use the big one, it would not likely happen, but it could.
Gotcha.
But last question, because we're gonna have to stop here then. So given that differential diagnosis, what would you do now? Because we'd like to, if possible, complete the suction DNC. We don't want to harm the patient or put her at risk. What might you do at this point then?
So at this point, I would call for an ultrasound technician or an assistant so that I can do a DNC under ultrasound guidance.
Perfect. Exactly right. Yes, you can use probes and dilators. You can actually track yourself on all. You can actually find out where you are right now and sort of figure out where you need to go to get into the cavity. You should very reliably be able to complete it, no matter what. It may take you some time. You may have to redilate and create a new passage in there, depending on what has happened. You're absolutely right. And that's exactly the thing to do. If, however, you have a concern for perforation, and this was a suction DNC, is there anything else that you might do at this point as far as evaluation?
It depends on how I perforate it. If I perforate it with the actual suction, then I'm concerned that I might have injured the bowel or such.
Yes.
So then at that point, then I would do a laparoscopy to take a look.
Perfect. Exactly. Yes. Right. With suction, if a suction cannula goes outside the uterus, it will grab onto anything it can. It could be some epiploic or a mesentery. We could at the very least have bleeding in there, but we could also have had a bowel injury. That's exactly right. Whatever happened to be in the cul-de-sac. That's perfect. Nicely done, Linda. That was really, really good. And that, I mean, one of the things is the uterine anomaly is the one thing that I think in the exam they're looking for when they ask about this. And we talked about this in our courses actually a couple of weeks ago or so. It's in the exam, be prepared for that. If you do a D&C where you don't get products, we should remember this, because as I've said before, during our careers, all of us will have this happen to us a few times where there is an unrecognized uterine anomaly and we are doing a D&C and we don't get what we expect to, and we should think about that. It's only, it's less likely, but we should always consider it, because the answer to it is then to go do it under ultrasound guidance, and in doing so, you'll actually identify the anomaly. That's very important. So that was very nice, because that was the first thing you brought up before we even got into preparation. That was the first thing in your mind. That was very, very astute and nicely done. Good job. Linda, we do have to stop in just a minute because they time these these sessions. Any questions or anything you'd like to talk about briefly before we stop for the evening? And I'll get to Dr. Riblos in just a moment.
I don't. Thank you.
Thank you. Let me jump down to Dr. Riblos, who I think has a question. There's a question mark by his name. Hang on, Mark, I'm trying to get you unmuted. Still trying. Let's see, Mark, you have yourself muted. If I see a question mark by your name. If there's a question you'd like to ask, just unmute yourself and we'll take a minute if you would like. Otherwise, if you can't, we'll stop in just a moment. Let me try once more. Not getting him to unmute, so I think we will have to stop for the evening. Okay, Mark, I'm sorry, if we're having a problem with that, we will have a session tomorrow. We can actually take up any question that you have, but I'm actually not able to get you unmuted. That's okay. Thank you to all of our candidates. As one of our candidates. Oh, hi, Mark, you're there. Hey, good job. Hi, go ahead.
Sorry about that. Just a quick question. This is my first webinar series. In general, how many questions do the examiner focus on your case and also the structured case?
Structured cases are completely different, and we'll be doing those on Monday and Wednesday. There's structured cases are very formatted, and there's not much variation here. The exam is very variable. The examiners will just sort of ask you a superficial question on one case and jump over and ask you a totally different case on another case, just to keep you on your toes and jumping around, and ask you 1 or 2 questions about another case, and then on the 4th case, they will dive in as we've done, and they'll spend 3 or 4 minutes drilling through a case, and then they'll jump up and they'll go sort of skipping around the surface again and ask you some more superficial questions. So it keeps you really off your toes and sort of off balance because you're changing topics on you very, very frequently. But in the course of a 30-minute discussion, they might spend maybe 12 to 15 minutes really drilling into cases. And the rest of the time, it's just sort of asking just superficial questions. And they're just trying a bunch of different things to see whether you sort of get the first question or two right that they answer, which is when you pass the case, or if you seem to have trouble with it, then they might dive in for that reason. But they're actually just testing your knowledge on a number of different subjects. And each time they ask you that first question, if you give a good answer to it, that's usually sufficient for you to pass, and they'll move on. Gotcha. So that's how it works, and it's pretty unpredictable that way. And all of us have that experience. It's disconcerting. But that's what they do. Great, thank you for asking that question. Thank you. I'm glad we were able to share that with everybody, because that's actually when we were doing our courses. For those of you who are going to be with us this fall, we'd spend a whole week working on that. But in these sessions, we don't have quite as much time, and I do want to be sure that everybody has a good idea of what to expect. So we do need to stop for the evening. Thank you to all of our candidates who presented. We actually got 6 candidates up this evening, just really wonderful discussions. Tomorrow, Monday, one of our faculty will be with you. We'll be doing some more structured cases. Have a very pleasant rest of the holiday Labor Day weekend. Thanks for joining us this evening.